Good evening, friends.
Recording started.
It is a privilege to welcome you all on behalf of API Delhi State Chapter and Bhagwati Hospital for this scientific session. This session is being organized by API Delhi State Chapter and Bhagwati Hospital, and this is sponsored by Abbott India Limited. I am thankful to Abbott India Limited and API Delhi State Chapter for cooperating me in organizing this session. I welcome Dr. M.P.S. Chawla, who is Secretary General of API Delhi State Chapter. I welcome Dr. Chawla. Please come on this. I also welcomed our speaker, Dr. Ramesh Garg, who is a senior gastroenterologist. Please come on this stage. And Dr. Tarun Kumar, who is also a gastroenterologist. He was available at Bhagwati Hospital. We have started the unit of gastroenterology at Bhagwati Hospital with the facilities of latest state-of-art gastroenterology instrument, upper GI endoscope, colonoscope, with the facility of narrowband imaging. The benefit of narrowband imaging is it identifies the vascularity of the ulcer and vascularity of the swelling that differentiates between the benign and malignant status of the swelling and ulcer. I request Dr. Prakash Chand, who is our senior interventional cardiologist, to present the bouquet to Dr. M.P.S. Chawla. Dr. Prakash Chand is available full-time at Bhagwati Hospital and doing all the interventional cardiology procedures. Thank you. Thank you, Doctor. Now, I request Dr. R.K. Gupta to present the bouquet to Dr. Ramesh Garg. Now, I request Senior Area Business Manager, Madam Mrs. Vasudha Verma, to present the bouquet to Dr. Tarun Kumar. Thank you, madam. Thank you for sponsoring this session. Now, I request Dr. M.P.S. Chawla to say a few words about the program and API. Thank you.
Well, even on a working day, it's very, heartening to see all of you present here. So lesser the better. At least those who are academically inclined, they are present here. That's very good. And it's an academic organization, and programs like this, they are, welcome. Anybody can organize in association with API Delhi State Chapter. And I think today they have chosen a very relevant topic to the internists who are practicing, and especially, I think first topic is etiopathogenesis of, and Dr. Garg will be speaking on this. Dr. Tarun will be speaking on it. And you all know, especially in patients with cirrhosis, after ascites, the second most common cause of hospitalization is hepatic encephalopathy. And we see a lot of patients. And now I request the first speaker to speak about etiopathogenesis of hepatic encephalopathy.
To all of you. I am greatly thankful to Dr. Pamnani for giving me this opportunity to discuss this important topic with all of you, and also thankful for the thankful to the people from the Abbott Pharma for providing a generous sponsorship for the event. The topic for today is the CME is hepatic encephalopathy, and I'll be discussing about the pathogenesis and the diagnosis of hepatic encephalopathy. So, hepatic encephalopathy is a constellation of neuropsychiatric and neurological symptoms in patients of cirrhosis, mostly seen in advanced cirrhosis. It is characterized by diminished alertness, deterioration of intellectual capacities. There are subtle, the neurological abnormalities can vary from mild letharginess and drowsiness to frank coma with decerebration. and their patient generally show some abnormal changes in EEGs suggested by slow waves in EEG. It is mostly reversible, except for the patient in very advanced stage of the disease, and which basically suggests a patient is having advanced liver disease and becomes over a period of time becomes a candidate for transplant. So the Working Congress of Gastroenterology in 1998, they divided hepatic encephalopathy into three types. The type A, according to the etiology as well as the severity of the encephalopathy. The type A stands for acute liver failure. So type A is encephalopathy seen in acute liver failure. B stands for bypass. So the type B encephalopathy is associated with portal systemic bypass but no intrinsic liver disease. And the type C stands for cirrhosis. So a patient with cirrhosis who is having portal hypertension and portal systemic shunt, he'll be classified, if he develops encephalopathy, he'll be classified as having type C encephalopathy. Now type C is the most common form of encephalopathy, so it has been further divided into the episodic variant, which can be precipitated, where we can definitely identify the antecedent event, or it can be spontaneous, which mostly is due to the worsening liver functions, or it can be recurrent. When a patient develops more than 2 episodes of HE in a year, he is classified as having a recurrent hepatic encephalopathy. The other forms are the persistent and the minimal hepatic encephalopathy. Now, a recent entity which has gained importance nowadays is minimal hepatic encephalopathy. It is a condition in which patient demonstrates a number of quantifiable and neuropsychiatric and neurophysiological defects, but yet they have a normal mental and neurological status of clinical examination. So what we do is, when we take our patient with cirrhosis and we subject them to mini mental state examination, the MMSC, and they are found to have a normal score in MMSC. Then if we suspect that the patient having subtle neurological variation, we subject them to special neurological tests, and some form of abnormality is detected on those tests. So those patients who have a normal MMSC but subtle defects on the specialized tests are classified as a minimal hepatic encephalopathy. Now, it is seen in about half to 1/3 or 2/3 of patients with cirrhosis, and again, as the severity of cirrhosis progresses, the frequency of minimal hepatic encephalopathy increases. The prognostic implication is that over a course of disease, it progresses to overt hepatic encephalopathy, and from the medical point of view, it has got a significant morbidity.